Hello, my name is Michelle Gillahan, and I'm going to be doing my comprehensive physical assessment on Tina Jones for week 8 of physical assessment, Aspen University, class N518. Today we're going to be seeing Tina Jones. Tina Jones comes here today and she presents because she needs a physical exam for health insurance at a new job. Tina Jones is a pleasant 28-year-old African-American female in no distress, answering questions in full detail. Ms. Jones is alert and oriented, maintaining eye contact throughout the interview and examination, and appears reliable to self-report. She is obese. She is in no distress. She is smiling, talkative, and free with information. Tina Jones has allergies to penicillin, the rash, which was diagnosed as a child. She's allergic to cats, causes itchy eyes and an asthmatic flare-up. Dust causes her to sneeze with asthmatic flare-up. She denies latex or food allergy. Medications that she's taking right now is Flovent, 2 puffs BID for her asthma, albuterol inhaler, 2 puffs Q4 hours PRN, shortness of breath, or wheezing, last used 3 months ago. Metformin, 850 milligrams BID for diabetes. She is taking a birth control, yes, 1 a day for polycystic ovary syndrome. And she also uses PRN medications of Tylenol, 500 milligrams PRN headaches, uses less than 1 time weekly, and Advil, 400 milligrams PRN menstrual cramps. She last used 6 weeks ago. She denies any supplements, she denies vitamins, and she is compliant with all her medications. We're going to skip right to the physical exam. If you want to look at her social history, medical history, family history, review of systems, that is all located already in the chart. So we've washed our hands. We're ready to start the exam. I'll explain to Tina what we're going to do today. So we're going to start on her head and neck. We're going to inspect her head. Palpate her scalp. And also inspect her hair while we are there. Head is normocephalic, atraumatic, scalp with no masses, normal hair distribution. We're going to now finish our examination of her head and neck, starting with her eyes. Eyelids, upper and lower. We're going to assess her eye movements. Striking her to follow our finger without moving her head. We're going to go in a rectangular fashion. And ending with convergence. We're now going to assess her visual acuity with corrective lenses. Now we're going to test the visual acuity of both eyes, but I'm not going to go all the way to the top because she has been 20/20 in each eye. So we are going to start here at 20/40. Now we're going to assess her peripheral vision. Can you tell me when you can no longer see my fingers? We're going to use a pin light to test for pupillary response. And also the noun ophthalmoscope, so we can do a fundoscopic examination. We see on the examination that the disc margins are round and sharp, but she does have some cotton wool bodies that we notice on fundus examination. No hemorrhage, otherwise normal. And we use the ophthalmoscope on the left eye, perform the same examination. See here in this fundoscopic examination, the disc margins are round and sharp. We do not see any retinopathy or any hemorrhage. The eyes are bilateral. Eyes with no lesions, no ptosis, no edema. The conjunctiva are clear. The sclera is white. The EOM is intact bilaterally with normal convergence. Pupils are equireactive 4 to 3 millimeters bilaterally. As stated, the right fundoscopic exam reveals cotton wool bodies with sharp disc margins. The left fundoscopic exam reveals sharp disc margins, no retinopathy. Visual acuity with the corrective lenses are right eye 20/20, left eye 20/20, both eyes 20/20. We're going to now move to the ears and just look at the ears. All while we're doing our looking at the head, the face, we are also always noticing the skin. Using the otoscope, first in the ears. And then we're going to look in the left ear. While we have the otoscope, we are going to also check the nares and then go back to the ear. Right nostril. And then again in the left nostril. While we're still working on the ears, we're going to perform the whisper test. The ear shape was equal bilaterally, external canals normal. Tympanic membranes were pearly gray bilaterally, no inflammation or discharge on either side. The right cone of light was noted at 5 o'clock, the left cone of light at 7 o'clock. The whisper test was normal bilaterally. The nasal membranes were a bluish pink, moist and patent bilaterally with no drainage noted. We are going to also go back and palpate the sinuses. The frontal sinuses and also the maxillary sinuses. You will notice there's no pain to palpation to the sinuses. And we are also now going to go onto her mouth and throat. We're going to visualize inside her mouth, suppress the tongue, pull it up. Push the tongue to the left, right, looking for abnormalities and lesions. We also notice her adequate dental hygiene, her test the gag reflex. So we're going to palpate the TMJs. I'm going to open and close her mouth. The mouth and throat, the moist buccal mucosa noted, adequate dental hygiene as noted, uvula midline, tonsils are normal without inflammation. The posterior pharynx is pink and moist, tongue is normal, no lesions noted. Gag reflex is normal. The TMJs with full range of motion bilaterally without pain or clicking. While we're here in this area, you're going to go assess some items at the neck that might belong in other systems, but we're right here. And so this is what we're going to do at this point while we're assessing her face and head. We're going to go and we are going to palpate the thyroid. You notice the neck is symmetrical. The thyroid is smooth without nodules or goiter noted. If you do look around her neck at this point, looking at the skin, you notice acanthosis nigericans and striae are present on her neck. I'm going to go to carotids, just to palpate. And we're going to auscultate the carotids. The carotids are 2+ bilaterally without any bruits or thrills. And we are going to be testing her neck strength and range of motion. Giving her instructions for each movement for extension, flexion, lateral bending, and then rotation. And the neck strength. Her instructions on turning her head to the right and left, with me putting a resisting movement. Tilting to the right and left with resisting movement. And tilting head down, resisting movement that I provide. I would like to add that again, while we're doing all these maneuvers on her head and face and neck, I'm looking at her skin. Notice, as what we talked about was on her neck, I do notice also on her skin, she has acne consisting of pustules and comedones that I've noticed throughout bilaterally both sides of her cheeks and near her hairline. She also has some excessive hair above the upper lip and also medial to both ears at the hairline. Last thing we're going to do while we're in this area is to look at her lymph nodes. We're going to palpate the cervical lymph nodes. Also palpate supraclavicular lymph nodes. And the last thing we'll do, we'll palpate for axillary lymph nodes. We have noticed in the final portion of the head and neck that there was full range of motion noted to the neck with all neck strength and all testing 5 out of 5. The lymph nodes we palpated, there were no cervical, supraclavicular, or axillary lymph nodes noted. Now we're going to go to her interior chest. While we're in the interior chest, we're going to be looking at respiratory and cardiovascular. We're going to start with just inspection of the interior chest for cardiac and for respiratory. We'll palpate PMI. Turning in the left lateral position to complete the palpation. Notice the PMI is non-displaced, no heaves or lifts. Wrist and tapping. We're going to auscultate cardiac points. We're going to be using the diaphragm and the bell. Also, Erb's point, which you will normally only hear in the left lateral position. Bell, starting in all positions. Bell. Warnick. Tricuspid. Mitral. Again, the Erb's point. We're going to continue in the palpation, and we are going to palpate for tactile primitus anteriorly. You know, this is in the respiratory. Again, we're doing everything in the area of the body that we're in at this point. We're going to percuss the anterior chest. And auscultate. The last thing we're going to do at this point is to use, because of our history of asthma, we're going to use a spirometer. We're going to ask her to blow into the spirometer. With the FVC of 1.78, the FEV1 of 1.549, the ratio of the two is 87%, which is actually very good. It's within normal limits, much better than she has been in the past. We're going to go ahead and examine the posterior chest before we talk about the findings, because they are all connected. We're going to inspect the posterior chest. We're going to palpate for tactile fremitus posterior, and then we're going to palpate for symmetrical expansion. We're going to look for symmetrical expansion upon inspiration. Next, we'll percuss the posterior chest. Lastly, we will auscultate posterior chest. For the respiratories, we have the chest expansion is symmetrical with respirations with no abnormal findings. Normal fremitus, both posterior and anterior. Symmetric bilaterally. Notice negative for bronchophony. Posterior and anterior chest resonant to percussion. No dullness noted. Lungs are clear to auscultation in all lung fields, both posteriorly and anteriorly. We just already discussed the spirometer reading, which is normal. We're going to talk about what we found cardiac-wise in the posterior and anterior chest. PMI is non-displaced, as we mentioned, breast and happy with no heave or lips. Regular rate and rhythm, S1, S2 present throughout, no murmurs, no gallops, no clicks. We will be discussing the pulses in the cardiovascular system as we hit the extremities in the abdomen. Even though they would belong in the documentation, we're going to still talk about them when we come across them as we go on further down the body. We're going to move to the abdomen. First, we're just going to do a visual inspection of the abdomen, noting that it's protuberant. Also notice some striae on the skin as we're noticing the skin as we move down. We're going to next, we'll do the palpations, followed by the percussion, and then the auscultation last. We're going to palpate the abdomen lightly in all four quadrants, starting in the right lower. No masses, no tenderness noted to light palpation of the four abdominal quadrants. We're going to palpate the organs. Palpating for liver. It is palpable 1 centimeter below right costal margin, which is normal. Also palpate for the spleen. Spleen is not normally palpable, as in this case, not palpable, which is normal. And then we're going to be palpating for right kidney. It is not palpable, which is normal. We do not feel any masses. And the same thing for the left kidney. It's not palpable, no masses. Now we're going to do a deeper palpation to the abdomen, all four quadrants, starting with the right lower. Using 2 hands to get that deeper palpation. Looking for tenderness, looking for masses. With deep palpation to all four quadrants, we note no tenderness, no masses. We're going to percuss the liver span now. Listening for the area of tympani to dullness. In the percussion of the liver span, we noted it to be 7 centimeters mid-clavicular line on percussion. We're going to assess for CVA tenderness. Bilaterally non-tender for both CVA areas. Now we're going to percuss the abdomen. Looking for tympanic and dullness. We notice tympanic in all four quadrants of the abdomen. We percuss for the spleen, no dullness noted. Now we're going to auscultate, again in the 4 quadrants, looking for vowel sounds. Sometimes you have to listen for up to 2 minutes at a time to get vowel sounds. They're not always constants. She does have active vowel sounds in all 4 quadrants. Also, you notice when we are assessing the vowel sounds, we again notice the stria in the protuberant abdomen and some excessive barry hair in the lower abdomen. Now, while we're in this area, we're going to auscultate the abdominal arteries, and this would be documented within the cardiovascular documentation. Auscultating for the aorta, no breweries. Bilateral renal arteries, no breweries. Auscultating iliac arteries bilaterally. No breweries noted. And finally, the femoral arteries. No breweries noted. At this point, this would end my abdominal exam. I'm going to go on to the upper extremities. We're going to look for, in the upper extremities, we're going to look at the skin. We're going to look at musculoskeletal. We also are going to look at cardiovascular as we palpate for pulses and look for edema. Upper extremities first. We are going to palpate the upper extremities. And look for peripheral pulses, our radial and brachial. Bilateral radial and brachial pulses are all 2+. Now we're going to look at the capillary refills of the fingers. For time constraint, I will not be testing all the digits from here on out. But I do need to test digits on each extremity. Capillary refill is less than 3 seconds. If you look at the nails look good. There are no ridges. We are going to also do position sense of the fingers while we were here looking at her hands. Asking Tina to close her eyes. Telling us which position her fingers were moving. To be documented within also neurological examination. Which position sense of fingers were both correct. And we're going to also test a couple of motor skills. This would also be documented within the neurological examination. Assessing for point-to-point movements. with each hand. She does have normal point-to-point movements from finger to nose. We're also going to assess motor skills, the hand movements. Asking her to turn her hands over while they are on her knees. She did normal, rapid, not having any trouble with the hand movements. We're going to continue some neurological examinations on her extremities. We're going to assess her light touch response in pain. Testing proximal and distal extremity and also her chest. Now we're going to test for soft. Back to the sensations, we'll be testing for sharp. And again, as we're looking for our extremities, we're looking at the skin, inspecting it. We are going to assess some hand and upper extremity range of motion and strength. So we are going to look at our hands first. With instructions on how to do this. And now assess the range of motions in her wrists. With instructions for adduction and abduction. Also with instructions for extension and flexion. Looking at range of motion of her elbow. Again, instructions on flexion and extension, and supination and pronation. So, assessing bicep strength. Instructions for curling her arms up. Against resistance, trying to push down. And again, fighting resistance. And test range of motion to her shoulders and then shoulder strength, adduction. Instructions across each arm in front of her body. Instructions on extension. back. And flexion. Instructing her to raise her arms overhead. And accessing her shoulder strength. Having her shrug shoulders up against resistance. Tina has shown full range of motion and full strength in her upper extremities, which will be documented in the musculoskeletal section. We are going to look at her deep tendon reflexes, her upper extremities. And now her left arm, deep tendon reflexes. DTRs are all 2+ bilaterally, and then tricep, bicep, and brachioradial. And then we're going to test the graphesthesia, pterognosis. Again, this is testing her neurological. She's going to see if she can see what we trace in her hands. Both were normal. We're going to put items in her hand to see if she can tell what they are by feel. Stereognosis. And the test was accurate in both extremities. The last thing, we're going to look at just her musculoskeletal system in general while we're looking at her upper extremities. I got out of that too soon. Sorry. This is a good time while we're expecting all her musculoskeletal system to also look at the skin on her body. And now looking at her lower body before we start lower extremity exam. in all areas. Get an overview of her skin to see if we see any abnormalities while we're looking at her general muscle tone. Last but not least, because we missed this when we looked at her hands, we are going to look at her nails. Notice there are no ridges, no abnormalities. Now her lower extremities. We're going to first inspect the legs for edema. See if we see any edema. We do not see any edema in either legs. This would be related to the cardiovascular and muscular system. We're going to palpate peripheral pulses. Check for femoral pulses. See our documentation in the cardiovascular system with the other pulses, the upper extremities. Femoral bilaterally, popliteal bilaterally. Posterior tibial pulses. And finally, dorsalis pedis. All pulses checked bilaterally. They are all 2+. They're all present 2+. Position sense of her toes. Now testing her part of her neurological system while we're looking at her lower extremities. Capillary refill. Again, I will just check a couple of digits on each extremities due to time constraints. Looking at the toenails at the same time that we are assessing capillary refill. Capillary refill is all less than 2 seconds, showing good circulation. We did look at the toenails then while we were there. Notice no ridges, no abnormality. They're not dusky, the color is good. And we're going to assess the motor skills heel to shin. Looking for point to point, as we did with the upper extremities. This would be in the neurological, motor, musculoskeletal systems, both. Those are both normal. We're going to assess their touch, pain, and light touch. Checking proximal and distal portions of both lower extremities. Checking all sensation, dull, soft, and sharp. Now we're going to assess the range of motion to the ankles and then the strength. The instructions for eversion and inversion. Then instructions for extension and flexion. Strength while we're at the ankles. Instructions to point her toes and then push like she's on the gas pedal. Range of motion to knees. Looking for extension and flexion bilaterally. Instructions, straighten her legs out for extension. Raising her knees up to her chest for the flexion. Assessing the knee strength. Instructions. Push against resistant. And finally, the hips, range of motion, and then strength. Abductor. Moving legs out to each side. The adductor, crossing leg over the body. Extensor, laying on her stomach, lifting her heels up to the ceiling. Finally, the flexor. Again, we're looking at all these in her lower extremities, but they will be documented in the musculoskeletal section. Good range of motion, full strength. Oh, the hip strength. Telling her to push her knees up against resistance to test for the strength bilaterally. And then lastly, we are going to do the tendon reflexes on the bilateral lower extremities. First, checking the patella and the Achilles. While we have her in this position, we're going to go ahead and test the left Achilles. Test back up here. HERs are all 2+, documented in the neurological section. And we're going to go to the full body, just a few things left. We're going to look at her vital signs at this point. Blood pressure at 128/82 with a mean of 97.3, heart rate 78, respiratory rate 15, SpO2 99% with a temperature of 37.2 Celsius or 99 degrees Fahrenheit. I'm going to assess her orientation, just ask her some questions. That'll be documented in the neurological section. She's alert and oriented ×3. I'm going to do real quick range of motion of her spine. At this point, just because this causes her to stand, so I've waited to do it at this point. Instructions. Just doing each section of her body at a time. This is a little bit more general. Extension, flexion, lateral bending from side to side. And then we'll have her do a rotation. From side to side. And just a good inspection of her skin, which actually we already looked at her skin. We did the musculoskeletal. We already mentioned that. These areas, anthosis, uricans, stria. Just do a general look again. We will have obviously looked at this when we did the musculoskeletal to do the general. Feet. We would take the last sections of these and do our documentation as the musculoskeletal, but I did them separately looking at various parts of the body because we want to examine the patient at the area that we're looking at everything on the upper extremities and the lower extremities at the time we're there, but then differentiating them and placing them in the proper documentation. Musculoskeletal, the bilateral upper extremities were without muscle atrophy, full range of motion to shoulders, elbows, and wrists. Bilateral lower extremities without any muscle atrophy, and also full range of motion noted to bilateral hips, knees, and ankles, full flexion, extension, lateral bending and rotation of spine. The bilateral upper extremities strength was 5 out of 5 in the neck, shoulders, elbows, wrists, and hands. And in the lower extremities, there were 5 out of 5 in the hips, knees, and ankles. Also good strength. Full range of motion in all the extremities, good muscle bulk and tone noted to all extremities. In the neurological, she was alert and oriented and noted by the questions we asked her. Her thoughts were coherent. We talked about her gag reflex being intact. She could shrug her shoulders, 5 out of 5 strength. The tongue was symmetrical, no abnormal findings. She was able to move it from side to side. The DTRs in upper and lower extremities were all 2+ bilaterally. Point-to-point movement in her upper and lower extremities were smooth and accurate. Her rapid alternating movements of the upper extremities were intact bilaterally. All her sensations were intact, soft, dull, and sharp bilaterally. And then the stereognosis and graphesthesia was also intact bilaterally, which would be documented into the neurological exam right here. And I want to thank you for sharing this assessment with me.